Thank you, Nipper. So for those just joining us, this meeting is being recorded. My name is Laurel Swerdlow. I'm with the Oregon Health Authority. Sarah Nipper is here as well, also with the Oregon Health Authority. And we additionally have Sarah Bartleman, who will be on deck to answer any of those hard-hitting questions for us. All three of us are excited to be here. Just a glance at today's agenda, we're going to be offering an attempt at an overview of healthcare expenditures in Oregon. We will then dive into some questions that we've pulled together, have some discussion, highlight what additional questions are coming out of this conversation, and then we're going to spend some time talking through what the upcoming meeting agendas will look like. We've taken the co-leads, Sam and Chuck Dr. Metz and Chuck have taken an attempt at outlining what the upcoming tags will look like. And so we'll be able to talk through that. And then we will have a moment for public testimony. Can I pause and just ask, is there anybody on the call at this time who is anticipating offering public testimony? If you could just unmute your mic and say so at this time. Okay, we'll have another opportunity at the end for me to check in on that.
This is Charlie Swan. I may want to give some public testimony.
Sounds good.
And we don't have a raise hand function or anything, so we should just sort of chime in. Is that if we have questions or?
That's right. And for future meetings, we'll make sure that that raise hand function is an option.
Okay.
Thank you. And Laurel, just an interruption. Under participants down below, if you click on participants, at the bottom left, there is a raise hand function. It may be awkward to use it, but for me, when I begin presiding, if you would simply wave your hand at the screen, I'll probably figure that out. And just to let everybody know, only my mother calls me Dr. Metz. She said she paid for the doctor degree, so she's entitled to use it. I'm Sam to everyone else, but thank you for the discretion.
I appreciate that. Next slide. Okay, so as I said, this is really a big picture presentation. We're going to attempt to break down where dollars come from and how those dollars are spent at the coverage level. And we're gonna attempt to break that down further into big buckets of services. There's obviously a lot going on in terms of how healthcare is funded in the United States and in Oregon. So figuring out where to start is definitely challenging, but we're attempting here, we're hoping to offer an overview of where we're at, knowing we will be able to dig deeper into some of these items as the tag progresses. So we're gonna kick things off with the national context, just like this big picture idea, looking at national healthcare expenditures. Looking at this slide, let's take a look nationally. Health spending totaled $74.6 billion in the 70s. By 2000, healthcare expenditures had reached about 1.4 trillion. And then most recently in 2018, it was up to 3.6 trillion. A note about definitions. Total health expenditures represent the amount spent on healthcare and health-related activities. So this includes administration of insurance, health research, public health, both from public and private funds. And we're gonna dig into that a little bit more. So in the next slide, you'll see that there are several different flows of dollars that go into this healthcare system. So if this slide was actually originally taken from the RAND Corporation report for a New York's attempt at a single payer, and we did our best to sort of augment it and Oregonian it so that it applies to our system. Remember, we are talking here nationally about a $3.6 trillion total healthcare expenditures. What this slide attempts to do is break down what those different flows are. So when we say total spending, what do we mean? Any one of these arrows could be its own presentation. We're going to attempt to give you some general context today for the total amount of money in the system and roughly how it's broken down. But again, we expect that you're going to have a lot of follow-up questions to dig into in future meetings and readings. Looking at this figure, you see these different flows for healthcare services from residents to providers. So those solid arrows are payments. Those are direct payments. So for example, premium out-of-pocket payments. Those here are shown in green. If you look at tax payments and exclusions, those are tax payments, credits, and exclusions related to healthcare. Those are shown in orange. And then the federal and state outlays and private claims payments are shown in blue. So I guess, Nipper, if you could just, with your cursor, because I realize you're the ones sharing the screen, those blue ones right there, those are what we just spoke about, the federal and state outlays. Going backwards now, we have the orange lines there, which are the tax payments, exclusions, and then those green lines are the direct payments. And then all of those flows go towards the healthcare providers, which then ultimately pull out the dollar value of healthcare received in purple. We have this slide a handful of times throughout the presentation because it's obviously a really complex slide, but we think it did a pretty great job at trying to take a very complex system and break it down into its individual components. Just a note about definitions. So we're going to be talking about both healthcare payments and expenditures and spending. Those are two different things. Oftentimes folks use them interchangeably, but we want to highlight that healthcare payments are payments specifically for healthcare services versus expenditures and spending. That's the dollar amount of healthcare services and associated administrative services received by an individual. So again, those are two different things. Spending the dollars that are spent may not be coming from the individual who is receiving those healthcare services. So for example, services received by a Medicaid enrollee are paid in part by that enrollee via taxes, but also in part by other by other citizens in the form of federal and state taxpayers.
So
I see that John raised his hand.
Yeah, I had a question. Where's like insurance payments? Are those an insurance company? I pay the insurance company a portion of that, some that goes to a provider.
Yeah, are you asking our premium?
Where's that? No, I have another question on this slide, but on that next slide of the two definitions, I'm a little confused by is my payment to the insurance company considered a healthcare payment or an expenditure spending?
It's a great question. My sense of this is that a payment would be a premium, and so are you both either premium or out of pocket? I mean, either of those I think would be considered healthcare payment. That's my understanding of this.
Yeah, Laurel, let me take a stab at this. I think the difference, and we can be clear, premiums are payments because you as the individual pay them to the provider. I think why we're providing this differentiation is when we talk about total costs and when we talk about what you as the finance and revenue tag might need to come up with, if you're only focusing on the payments that are made by individuals, you may not capture the total costs that are currently spent in the system, some of which include the premium dollars. So premiums we would consider a payment. Premiums are included in the total of all the expenditures and spending in the definition on the right as well.
Okay, and then I had a question or comment on the prior slide.
Please.
Right, so I think it's important to note that two things, that sort of the dollars on each side of that, the three in the middle, don't necessarily add up, right? I mean, I pay more in income taxes maybe than my taxes are going to support Medicaid, right? It's only a portion of my personal income taxes are going to Medicaid, as an example. And then where some of them it's one-to-one or even better when you have like the provider tax one. And then the other thing is, the issue of Oregon employers getting foregone wages. I think economists can debate and still debate will continue for decades, what portion of a benefit comes out of your wage. Even, I mean, we know that when bargaining happens with unions, they'll say, well, we'll take this, keep our health care, that's going up 15%. They may be agreeing to less of a pay raise, but it's not always a $1 to dollar.
I think that's a great point. And I think your earlier point about the arrows, essentially those arrows aren't to scale. The dollar amount, I think that's what you're getting at. And I think that's a great point. And some of the subsequent pie charts and graphs, I think, try to break apart really how much each of those arrows, really try to create some scale to those arrows.
Right. I mean, on the issue of wages, I mean, it's sort of like, yeah, if we came up with a plan and the plan did a good job of getting all the employers in Oregon to say, oh, it's better to have the public plan, let's say, and they stopped providing health and they stopped having to pay for health insurance, I'm not so certain the wages would go up by that dollar amount, right? So.
No, I think it's a great point.
And we wouldn't lose, I mean, I don't know if we would get more in, that much more in income taxes out of it either. So that's because of that. You know, we're spending 1.6 billion for that. We're not going to capture that. So
it's a great point.
Move on.
And as you said, it's something that I think is very apropos for the work of this tag, and definitely something that we should be that we'll be flagging in the notes for consideration as we continue this conversation. So another way to represent the total healthcare expenditures in 2018, this slide here, is where those dollars came from. So if you look obviously at that big section, the health insurance, we've attempted to break that down into the different payers within that Pac-Man slice. And that obviously includes, we'll get to this further on, but it includes private health insurance, Medicare, Medicaid, CHIP. And then looking at those other components, we have out-of-pocket expenditures. We'll talk a little bit more about personal contributions later on, third-party payers, and other programs that contribute, that pay into the system. So this is another way of representing that smaller slice that we just saw, that the health insurance basically broken down so that you can see you can better see the scale of these various payers. We have private health insurance comprising 34%. This is national. Then we have Medicare, Medicaid, and out-of-pocket again. So those two slides were addressing where the dollars came from. This slide's addressing where they went. These are I want to note these are CMS categories, and they're broad. And that's ongoing when we think about the categories throughout this entire conversation. It's important to note that those categories, you know, there may not be a singular definition across states, but these are the CMS categories that they give us. So we have here that other slice. We attempted to break that down further for you all. We have the home health, other residential personal health care, other medical equipment, that kind of thing. And then all of these smaller components. We have a slide further on that kind of tries to outline in Oregon how much, what those percentages are as compared to the national average. But this is an attempt to give you a snapshot of where those dollars are going nationally. So again, this is the that smaller pie chart broken down so that you can try to see the differences. I'll pause here because Chuck did raise his hand. No, Chuck didn't raise his hand. I'll keep going. So we have, again, broken down where those dollars are going. Hospitals are the largest component. Physician services, prescription drugs, nursing, home health, and dental are those smaller components at the end. So we wanted to note that sponsor isn't quite the same as payer. So it's really common to talk about health spending by payer. This is where the coverage is coming from, Medicaid, Medicare, commercial. But that can really gloss over where the money for those programs comes from. To Chuck's point about, we are paying into these programs, and those programs are ultimately delivering the services. Sponsor tries to speak to, again, where the money for those programs are coming from. So we can also look at health spending by sponsor. It's the entity that ultimately is responsible for financing the bill, regardless of the payer. So you can see that households, when you look at it by sponsor, households have a significant share of the total bill. Again, we're going to talk about personal contributions later on, but this is definitely something to consider when we're thinking about who right now are the folks paying for healthcare. And I think, Chuck, this is also getting at your question about the personal contribution to private insurance, and the fact that while private insurance, while we say that they're the folks paying, obviously households are paying into those plans as well as into the public programs. Okay, so that was an attempt at a really quick national snapshot. We're going to move now to Oregon, try to speak to what the total amount spent in Oregon is, how Oregon's spending compares to national trends. Again, there are lots of data sources and ways to answer these various questions. We're going to start by looking at the CMS data, and to have a direct comparison to national data. But I want to note that the CMS data that we have right now is 2014 data. We're going to attempt to pull together some 2020 estimates in a second, but this slide does give us a sense of where Oregon is at generally in this past decade. So total healthcare spending in Oregon was about $40 billion. Again, this is in 2014. And remember, this total health spending, it's that entire diagram that we were going through. It includes spending for all private and public services. So as I said, we did take an attempt to make some estimates for 2020, knowing what we know based on national per capita expenditures and Oregon per capita expenditures. So trying to balance, again, what we know from the 2014 data, we are able to create an estimate that by 2020, we're at around $47 billion. So I'm sure you guys have seen this pie chart a million times before. Maybe I just feel like I presented a million times. Who knows if you've seen it a million times. This really tries to break down insurance coverage in Oregon by payer. So again, we have the 6% uninsured. We have this state as the largest payer, technically, when you look at Medicaid, PEB, and OEB. We have the employer market and individual and Medicare.
So if I have employer provided coverage, but I'm paying for other family members, is that split between the two? You
have employer.
How does that, or is that still?
Bartleman's shaking her head no, and she's the data head here.
So this data is based on the Oregon Health Insurance Survey, which asks about how individuals are covered. So this is sort of based on where people are. I think that survey does get into some more granular detail. So for example, Chuck, I think your question, if you said I was covered by a small group, but my other household member was uninsured, I think both of that would be reflected in these percentages because this is for the overall population.
My question was, if I was asked, how much do you pay for insurance a month? I'd say, I pay $500, but I get my insurance from my employer. The $500 is getting my wife on my same plan through my employer.
Yeah, so this is just looking at the percentage of people who have what type of coverage. It doesn't have anything to do with how the payment for that coverage goes.
Okay.
This is people. This is people.
Right. So, but is my wife considered employer group because she got it from me?
Yes.
Or is it, yes. Okay.
If your plan is also an employer group plan and you're on the same plan.
Right. Okay. Thanks.
It's a great question. So looking at the percent of total healthcare spending by payer, again, this tries to give you a sense of where we are in comparison to national numbers. Oregon spends a little less on Medicare and private and a little more on Medicaid compared to the national average. I'm so sorry, I'm hearing a feedback. I can push it through, but I wanted to see if there's anyone who could go on mute. Thank you. The national average includes states that have not expanded Medicaid. So that's something to note in comparing the two. So
I have a quick question, Laurel, before you move on. When we're talking about total healthcare spending in Oregon, I think the previous slide to this, it was 31.9 billion, something like that. When we're talking about Medicaid expenditures, are we talking only Medicaid that flows through the Oregon Health Plan?
Yes. Go ahead, Sarah.
Let me take this one. So in this graph that Nipper is showing now, this is total healthcare spending, the 32.1 billion. This is using 32 billion. This is using the CMS estimates, and that does include things like long-term care and other dollars that might be sort of in a Medicaid bucket, but not delivered through, quote, the Oregon Health Plan. We're going to talk more specifically about the Oregon Health Plan budget in a few more slides.
Great, thanks.
Yeah, great. Thanks, Bartleman.
Sarah or Laurel, I have a question just briefly,
Yeah.
if I might add. When you have the federal expenditure indicated, does that include the federal match for Medicaid?
Can you say that again? Go ahead, Sarah, if you get it.
John, I'm going to have to double check that for the total spending. I think this graph does include the federal match because this is all dollars that are going into Oregon, but we're going to break down the OHP budget with state share and federal share in a few more slides. But can we confirm that as a follow-up?
Yeah, absolutely.
Sure. Thank you.
So again, right now we're still looking at total health spending. There's an entire section on Medicaid just to flag. We wanted to break out Medicaid because we wanted to make sure that we're thinking critically about state funding, essentially. But still, we're still here in the total expenditures section. So, okay. Again, there's lots of different ways to slice healthcare spending. So one common way is per enrollee. So how many dollars were spent on average for each member enrolled in certain types of coverage. Looking at this comparison to national numbers, Oregon spends a little more on Medicaid than national, which makes sense. As I mentioned earlier, the national includes states that that have not taken advantage of Medicaid expansion, which is why we spend a little bit more. We spend a little less than the national, again, on Medicare and commercial. You can also see that costs vary depending on type of coverage, and there are a lot of factors that go into that. Price utilization, demographics, covered benefits, all of which are considerations for you all in designing your plan. For example, a plan with older adults who need more care and covers more benefits is likely going to have higher per enrollee costs, as we see in Medicare. Oh, Cheryl, yeah.
Hi, I have a question. I think in one of the charts, it looks like the percentages of Medicare, Medicaid, and private add up to about 100% of healthcare spending. Yeah. And I think that we don't want to miss the point that actually state general funds subsidizes quite a bit of the total healthcare spending. And I think that we should show this. The fact that like Medicare doesn't pay for a lot of behavioral health, for example. With Medicaid, there's a state general fund match. Also, there are a lot of services that aren't paid by Medicaid, private, the same thing. I think it'd be really telling to show to have another column that has state, county, foundation or grant subsidized healthcare.
That's a really great point, Cheryl. And I know in earlier slides that were at the national level, we attempted to sort of break apart some of those other programs and county level contributions. However, it's a great point that it's not broken out into at the state level. Bartleman, do you have any additional thoughts on that?
Yeah, I think you're making a great point, Cheryl. Thank you. I think we can't say this enough, that there is no single source of truth. And we're pulling data from multiple data sources from multiple years. And in some cases, we're limited to what is provided. So some of the 2018 data is available nationally, but not by state. Some of the by state data is not broken out in the same way. So this is a bit of a mix and match. And I just want to really emphasize, we are pulling all of this together, recognizing that it's kind of a grab bag to help answer your questions and provide some grounding, but there is no sort of perfect, we can just go to this database and spit out the numbers in exactly the way we would all want, and we recognize that. So I guess I'm saying apologies in advance for some of that frustration.
Okay. So lastly, we did get some questions about, lastly at the Oregon broad level, we did get some questions about what services are being funded. And one thing that we wanted to highlight was primary care and how much we're spending on primary care versus other services. We don't have a comprehensive understanding of how much money is spent on primary care versus specialty care, but we do have some payer data from 59% of payers, or 59% of covered Oregonians, which includes both claims-based and self-reported claim, non-claims-based activities. Looking at these 4 different broad categories, they spent close to $1.5 billion on primary care, or about 13% of their total spending. CCOs had the largest share of spending on primary care at about 15%. Medicare was lowest at about 10%. This broadly, I think, is one way to try to be thinking about where the dollars are going. And we know that, obviously primary care is an important component when we think about price and wanting to be emphasizing prevention. Again, this is only data for 59%. Those other 41% of payers are smaller commercial carriers as well as self-funded employer plans. Lastly, looking at,
excuse me, Laurel, I think Dwight had a question.
So sorry, Dwight.
I did. Back to that previous slide where you're breaking that down, you have that entitled Medicare Advantage. Is that just Medicare Advantage, or is that all Medicare?
It's Medicare Advantage.
Okay, so we've eliminated a lot of Medicare in this.
Yes, that's a great point. When I just said the 41%, Nipper, I know that. Are you on? Can you speak to that? Oh, no, going back to that slide that we were just on. Yeah.
Sorry, I tried to unmute myself and the slides went crazy. Yeah, no, that's right. That is a big chunk of the missing.
So that 41% is all Medicare, the self-insured.
It's Medicare fee-for-service, and part of that is because this is an all payer, all claims database-based report, and the legislation that requires us to do this reporting on primary care spending for payers limits to who we're looking at. And there's a whole lot of nuance about Medicare Advantage versus Medicare fee-for-service in Oregon and what gets reported where. So this report only encompasses Medicare Advantage and not Medicare fee-for-service, because that's coming through more of a federal layer than a plan layer.
So would supplemental Medicare, that is private insurance, would that be, that's also not in this?
That depends. So yes and no. I think depending on if they have if that dual coverage is in a commercial plan and that commercial plan is not self-funded small employer, then it might be here in these orange commercial data points. Okay. If not, if it's a self-insured dual coverage, then no, because we don't have that ability to collect self-insured data.
Okay, thanks.
Glendora, you have a question. Be sure to unmute yourself.
Yes, thank you. I'd just like to know, do you guys have any kind of tracking system that would show the patient outcomes per insured by each of these health plans? For example, can you tell me the patient outcome improvement that ensures the Medicaid and Medicare dual populations? What are the patient outcomes compared to, say, the outcomes from patients who have health plans provided by PEBB and OEBB?
Hey, Glendora, this is Bartleman. And I would say that just like there's no sort of standard definition that everyone uses nationally for primary care, there's no standard outcome report. That said, there are a lot of different outcome measures that have been identified, and we can send some additional reports around that talk about how some of the different payer types or plans perform on those quality measures. It is going to be a mix and match because not all plans use the same measures. So for example, there's pretty good overlap between the measures that CCOs and PEB and OEB plans use. There's legislation that sort of requires them to all use the same outcome measures that they look at. We can overlap some of that for commercial plans. Some of that's publicly reported for Medicare Advantage. We can definitely share more information, but again, I just want to note that there's no single sort of definition of outcomes and no single report where that all lives.
And one follow-up, isn't that important in us evaluating a robust system that is going to perhaps take some sort of precedence over these health plans? Because as they are now, currently, they are not working for all Oregonians.
Glenn, I would like to say that this is an important question for the members to discuss. I'm not sure that this is something we want to give to the OHA staff when they've got other material to present. Please bring this up after the presentation. There are peer-reviewed studies that do address partially your question, and we should talk about it.
But it's not, so if we're talking about financing and revenue, don't we need to know this before we reach a decision as to the best approach or financial revenue plan to use?
Yes, we do. I don't think it should be part of this particular presentation, which is an overview of current spending. I believe outcomes are important and deserve a separate discussion.
All right, Sam, thank you.
So one last view, trying to break down primary care compared to specialty care. Bartleman already highlighted this, and I'll emphasize this again, that there isn't an official definition for primary care. So for example, sometimes we count certain services as primary care, sometimes we don't. OB-GYN is an example of that. Some states count it as primary care, others don't. In Oregon, we have a legislative requirement to measure how much is spent on primary care, and we do have a specific definition that we use for those services. So, you know, who are primary care providers? These include folks, physicians specializing in primary care, obviously, family medicine, general medicine. OB-GYN is included in this state. There's a long list of folks who are considered primary care in the primary care spend report. If you have questions about that, the link is down there at the bottom of the slide. Again, you can see the way that these dollars break down across payers, just to get a sense of where these dollars are going.
Laurel, this is Chad.
Yeah.
The other thing is it does not describe the influence primary care has on specialty care. So primary care, in addition to its direct spend, obviously incentives and so forth can create an area where they influence specialty care as well, and hospital care for that matter.
That's a great point, Chad.
You know, I just can't resist being an old guy. It's amazing to see that Medicaid is a better payer for primary care than commercial. And And you know, certainly to the degree I've been able to travel around the state for the Oregon Health Policy Board, it is not unusual to hear primary care doctors, you know, say they prefer Medicaid. And as a result, sometimes it can be more difficult for commercial folks to get access than to the CCOs. And it's just interesting to see that dollar figure. That's
John, I think that's a success of the state, really. I think
I do too.
Of their work.
Yeah.
I'm going to hand it over to Nipper.
Wonderful. Thanks, Laurel. And I'll just ask if you have comments or questions, just go ahead and jump in rather than raising your hand, because it's hard for me to see while I'm sharing slides when folks raise their hand. So don't feel free to interrupt. So we're going to spend just a few minutes here talking about Medicaid, because obviously that is the pot of dollars that we have more data on here, as far as what are our revenue streams currently paying for Medicaid, and taking a look at our budget as well. Oops. There we go. So we're looking at this diagram again here, just to say that we will be focusing, for this part, we're focusing on the blue. We've got Medicaid fee-for-service claims, so like those folks who are open card. We've got the capitation payments, which are payments that we make to CCOs, that the state makes to CCOs. And then we have claims that the CCOs are making to healthcare providers. So that's sort of the Oregon Medicaid system as we're thinking about it from a dollars perspective. And just bringing the slide back up one more time, just to refresh everybody's memories, that we do spend a larger proportion of our healthcare dollars on Medicaid. And as has been brought up, like, this is certainly not a perfect diagram or graph that represents all possible like permutations and combinations here. But Oregon, I think in part because we tend to have a more generous Medicaid program, we are an expansion state. More of our healthcare dollars are spent on Medicaid than compared to the national picture. Okay, so this is the governor's budget for the biennium. So we're now switching. A lot of the figures we've shown you up to this point are annual. You know, in the state we do biennial budgeting. So this is on a 2-year, these dollars are based on, you know, a 2-year period. And so this is the budget for Medicaid, which is not quite $20 million. And so almost 3/4 of that is federal dollars. And then we have only 8%, which is from our state general fund. The remaining 19% comes from other funds. And those other funds, so here's our green pie here, our 3.8 million approximately. Oh, that doesn't quite match up. I'm seeing that now, so I'll have to figure out why that is. But anyways, this proportionally, the other funds here are, you know, made up of the hospital tax, tobacco tax and master settlement, tax on insurers, drug rebate money, OHSU transfer money. So that is the roughly 20% of our Medicaid budget here in Oregon.
What's the OHSU transfer money?
Bartleman, is that something you can speak to a little more?
I would rather send you the official answer in writing rather than get it wrong.
Okay.
Okay.
If I were to guess,
That's fine.
If I were to guess, I would guess it's money going to OHSU for the operation of their programs.
And there are some requirements around that and for what it covers, but I don't want to get too far over my skis.
Great, thank you. So this is something that I think is just important to keep in mind as we're thinking about who Medicaid in this state, who do we cover under OHP versus how is our money spent, that the people and the dollars, and this is true, I think, were you to look at almost any state, it would probably look something like this. But just to keep in mind that OHP covers an awful lot of kids. So 41% of our OHP population is children and young people, 0 to 18. And of course, they tend to be healthier. And so they only make up about 22% of our spending. Conversely, folks with disabilities are about 8% of the OHP population and make up about 19% of the spending. It's just, I think, some important context as we think about who we're covering versus what we're spending. Okay, I'm going to turn these few slides over to Bartleman here.
So we had a couple of questions about the tobacco tax and the provider tax and how those worked and how much of that money was going to healthcare in Oregon. So we want to dig into these two funding streams just a little bit deeper. So these are two pie charts from the new state economic and revenue forecast that came out in December. So sort of hot off the press. And on the left, we see the 19 to 21 biennium. And on the right, we see the 21-23 biennium. So again, 2-year Oregon budget cycles. And this is how the cigarette and tobacco tax dollars are distributed. Oregon has requirements in statute for how both the cigarette and the tobacco tax will be distributed. They're distributed differently. So for example, the cigarette tax goes to more categories than the tobacco tax. There are fewer distribution categories for the tobacco tax. I've collapsed the data here in this slide so you can see holistically, but there is distinction. And if you go look at the underlying report, you can see the cigarette tax and the tobacco tax separately. Both of these are, yep.
I have a question. Sorry to interrupt. What's the difference between money to the Oregon Health Authority and money to the Oregon Health Plan?
I am getting there.
Sorry. I'll be patient.
One more introductory comment, and then I'll talk about that. So both of these charts include Measure 108, which recently passed and increased the tax and changed the distribution. So because these are biennial dollars and that tax takes effect January of 2021, we're seeing 6 months worth of that tax in the pie chart on the left and the full 24 months of the tax estimates on the pie chart on the right. That also explains one of the big changes we see when we look between those two things. So these are categories that are explicitly defined in statute where it says X percent of the cigarette and tobacco tax dollars goes to fund the Oregon Health Plan. Then there are a whole bunch of other things that the dollars are directed to that flow through the Oregon Health Authority. On the left, in the current biennium, this is a little cleaner, but with Measure 108, things got a little more nuanced because Measure 108 says that all of the 90% of the funds after enforcement of Measure 108 are directed to the Oregon Health Authority for the Oregon Health Plan. So a good chunk of the Oregon Health Authority's 45% in the pie chart on the right really is for the Oregon Health Plan. So this is the statutory language and not the actual dollar language.
So as a practical matter, we'd add them together and compare them?
Well, not quite, because there are other things that do go to the Oregon Health Authority for things other than the Oregon Health Plan. So that includes tribal health providers, urban Indian health programs, regional health equity coalitions, culturally and community-specific health programs, state and local tobacco prevention programs, cessation programs, and and a whole bunch of other stuff. So it's definitely a much smaller slice. It's only about 10% of that 45%. Yeah, I'm really slicing and dicing, but essentially a good chunk of that those dollars for the Oregon Health Authority in next biennium are for the Oregon Health Plan. Sorry, any more questions about the tobacco tax before we jump to provider tax?
I just have a comment. I'd like to use this slide for my community mental health advocacy.
Yeah, absolutely. Let me know if you want the underlying data for the pie charts. Okay, Let's talk about provider taxes. So provider taxes are specifically a tax on healthcare providers that are used for the state share of the Medicaid program, which allows the state to obtain federal matching funds. So in general, the state says, I have these many dollars that I've contributed as a state, and therefore I can draw down this many dollars from the federal government as a match. So states can tax providers to generate that state share. In 2019, all 50 states had at least one type of provider tax in place, and most states had multiple kinds of provider taxes. So I think it's pretty easy for us to just say provider tax, but that's a category. And in Oregon, we have multiple kinds of provider taxes. And there's a whole history of how these provider taxes have changed and been expanded over the years. In the presentation linked at the bottom of this slide, you can find that whole history if you want it. But we have 4 taxes. One is the hospital assessment that specifically funds the Oregon Health Plan and other hospital initiatives. And that is a tax on both the DRG hospitals, or the large urban hospitals, and the rural type A and B hospitals. Those hospitals are categorized separately. They have different tax rates. And so they're listed as sort of two separate programs, but sort of in general, all hospitals have a hospital tax. Then there's an insurer assessment, which is a tax on premiums that are paid, and that supports Oregon Health Plan and the commercial reinsurance pool. And then there's a long-term care facility tax, not a fax, that offsets the DHS general fund. So we're probably not going to talk quite as much about that one as we are the hospital assessment and the insurer assessment, but it is floating out there as well. On the next slide, you can see what the provider tax revenue looks like. Again, this is coming out of the latest economic budget forecasts. You can see we're now looking at the fiscal years. So we're back to annual, but on a fiscal year, not a calendar year cycle. And this is the total revenue that's been raised through the provider tax, and whether that's going to OHA through sort of those first 3, the hospital tax and the insurer tax directed for the Oregon Health Plan, or to DHS for the long-term care facility supports. You can see the projected taxes for the future fiscal years, and there was a House bill in 2019 that passed that changed up the provider taxes quite a bit. So it pushed out the sunset date of some of the taxes until 2026. It increased the tax percentages a little bit here and there. And so this is what we're projected to bring in, and it does increase over the next couple of years. Based on some of those changes that were made from that House bill, Legislative Fiscal Office is estimating, let me see if I get this right, 137 million and 184 million in federal match for the next, for the current and the next biennium based on those changes. So we've increased the tax locally. It's generated more revenue in state that lets us bring down more federal match because we now have more state share to bring to the table for that match.
Can I just throw my 2 cents worth in there? As we're thinking about the future, it's going to be important to try to leave this in place in some manner because it's curious that hospitals are taxing themselves in order to do this, but it ends up being a net wash for them. Because basically they end up taxing themselves, but then they end up getting greater reimbursement as a result of the tax. So it's kind of complicated, but I think it's important when we're thinking about a single payer that we want to pay attention to the sort of gaming that provider taxes are for federal match.
Yeah, I think it's really important to reflect that these dollars go back, they go straight back out to the health system. They are not, they don't go into general fund, they don't go for sort of other projects, they go back into paying for Medicaid services.
Is it also fair to say that the tax coming from insurers may not be there, since insurers may not be there under a single payer?
If you're saying, are we going to get rid of all of commercial insurance plans, and so there won't be any commercial insurance premiums to be taxed, then yes, theoretically, if you play that out, yes, that tax revenue would go away. Yeah,
no, it'll be an interesting discussion when we get to will commercial health insurance be prohibited? I suspect it won't, but I think I'm more getting at, I doubt the insurance industry is going to be eager proponent of being taxed for something they may not be participating in.
John, I think it's a great point.
Yeah, you know, I mean, Chad, I mean, I think this is an interesting topic, because I think we definitely need to figure out how to structure this so that the hospitals would continue to do this. Other providers. I'm just not sure that the insurers will be in play, you know.
I want to note something else, John, and some of you may have been around for the 2019 session and have more insight than I do, but usually, historically in Oregon, the hospital tax has been sort of updated every couple of years. This 2019 bill was a little more unusual in that it pushed the sunset date out to 2026. So the hospital tax is now in place for 6 years, and that's newer, that this is not sort of up for renewal and up for renegotiation. So just note that things like that are sort of continuing to evolve, and this is sort of locked in for the next couple of years at least.
Yep. The other comment I would make here is, and Chad may have a comment about this. From my vantage point, I saw incredible differences in rural towns and in rural Oregon in the decade where the Medicaid waivers came in so well for Oregon. That really health is a huge business in rural Oregon, and we need to be aware of that. And this is one reason why. And I hope whatever we do, we figure out a way to maintain that. And the exposure I've had in Oregon, it is amazing to see how much ownership there is in Eastern Oregon of that resource, that asset, that wealth, and how proud I think folks are that money's staying in Eastern Oregon and Southern Oregon, and not coming through Portland and a few dollars disappearing or more than that here and there.
John, I'd like to acknowledge what you and Chad and Bartleman said about gaming the feds to protect, so that in creating a single payer plan, we don't forsake vital federal dollars. I'd like to pick this up again at another time, because there's a lot of material that Bartleman still needs to get through. And I'd like to do that. I'd like to give her enough time. So Bartleman, would you?
Yeah, I think I'm actually done with the tax slides, and I'm going to kick it back to Nipper, right?
That's right. Thank you. Okay, so I am going to close out our data presentation here by just talking a little bit about personal healthcare expenditures. And so as we look again at our diagram, we're really talking about here premiums, co-pays, out-of-pocket payments that households are making or individuals are making, whether that is to employers, you know, well, to insurers, I guess, or to providers themselves. So that's what the focus of this part of the presentation is. Okay, so we're looking at per capita data here. So this is between the decade of 2010 to 2019. If we're looking across the US, we see that healthcare expenditures per capita in the US are up 36%. And these are all dollars adjusted to October 2020 levels. So up 36% over a decade, up 14% from 2018 to 2019. And this is data from the Bureau of Economic Affairs. And if we put Oregon on top of that, we see that the trends in the state are really similar, but we have seen our per capita healthcare expenditures increase a little faster in the state than at the US. You can see we started out in 2010 a little below the national average, and we ended a little above. So in Oregon, our expenditures increased 44% over the decade and up 5% in the most recent year of data. And if we compare it to nearby states, we are consistently about 7% lower than the state of Washington. 12% higher than Idaho and 5% lower than California. California's line actually I think is pretty interesting because they started very close to the national average and significantly below Washington, and they're just right up about to the same level that Washington is now. But I think the takeaway here is people are spending more and more out-of-pocket dollars towards healthcare at a per capita level. Relative to other states, our healthcare spending has increased at a faster rate. So this graph here, I'm going to explain it because there's a lot of numbers going on here, but essentially this is showing Oregon's ranking between each year between 1997 and 2019, our ranking of healthcare per capita spending. So, and for being ranked first means you have the highest, and being ranked 50th means you have the lowest, 51st, I guess. So in 1997, we were very close to the bottom. We had the 45th highest healthcare per capita expenditure amount at $24.55 per person. And you can see as we made it into the 2000s, our ranking has steadily gone up, which is worsening. And in 2019, we had the 25th highest healthcare per capita expenditure amount at almost $7,600 per person. So we're sort of right in the middle. This is looking at personal healthcare spending in a slightly different way. So this is just looking at money that's spent on premiums and deductibles for employer-sponsored insurance. So just folks who receive insurance through their employer. And in this graph, you can see, so as of 2018, our per capita spending was $6,769, which is about 11% of the median state income. And this puts us, right in there, along with many, 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 many other states. So you can kind of see that, most of the west half of the US and a lot of the Midwest and Mid-Atlantic is in there too.
And I would add, Nipper, that I think there was a good question earlier, the comment about sort of an individual who is only insured for themselves versus the household or the family insurance. And we see similar trends whether or not we're looking at individual or family contributions. And if anyone's interested in that difference, there's some really good data out of University of Pennsylvania that tracks single versus family contributions.
Thank you for that context, Bertelman.
I had a quick question on that previous slide where it shows the personal health care spending.
This?
No, the previous slide, the rankings where we went from 45th to 25th, whatever it is. And talking about that being worse, is this, when we talk about personal care, health care spending, this is all premiums, everything, Medicaid, all of that. So when you talk about it being, we're in a worse position than we were in 1997, that seems relative in terms of Medicaid expansion and so forth. So to say that we're in a worse position is, I'm not sure, is that?
You're saying because more folks have insurance? Is that
right? With Medicaid expansion, we're spending more than other states that don't have Medicaid.
So Dwight, I think that's true for the earlier slides that we looked at when we were looking at total healthcare expenditures, but this is specific to the personal expenditures, so out of pocket. The difference between that payment and the spending that we talked about. So in this case, even though we are a state that has expanded Medicaid, that we don't have copays or premiums for Medicaid that the individual pays.
So this is just personal expenditure.
Yes.
Okay. Thank you. That makes sense.
Are there any other questions on the personal healthcare expenditures or per capita expenditures slides? Okay. So that was a lot of information. And Laurel kind of laid it out in the beginning that certainly we know that this is, we just really tried to give you a big picture here. You know, as Bartleman said, unfortunately, there's a lot of different sources of data and none of them represent the perfect information or the definitive source of data. So I know we pulled from a lot of different pieces here, and there are probably things that you want to know the answer to that we didn't present here. And I think part of the discussion is to help us kind of flesh that out. But going through this information, we just tried to pull out a few pieces that seem worthy of highlighting, and I'm sure some of you have other ones as well, but I just wanted to highlight these pieces. So at the national level in 2018, we spent about 3.6 trillion on healthcare, and a little more than a third of that was on private insurance, 16% on Medicaid, and spending on hospital and physician services was about half of that. In Oregon, you know, unfortunately, the comparable data we have from CMS is 2014, as Laurel noted, but in Oregon, we spent about 32 billion in 2014 in healthcare. And as we've said a couple times, we spend a greater share of our money on Medicaid, less on Medicare and private than the US as a whole. We don't have an exact dollar figure for our healthcare spending in Oregon, but a reasonable estimate of what we're spending in 2020 is somewhere around $40 billion. So if you're looking for a ballpark figure, how much money do we spend in Oregon on healthcare? About 40 billion is probably not too far. Oh, and this was done before we had our updated 21-23 slides. But anyways, in the biennium that is just finishing up here, we spent about 15 billion on Medicaid. These numbers are not that dissimilar from what we showed you, but about 3/4 of that was federal dollars, and only 7% was from the general fund. We are expecting to bring in about $800 million from the tobacco tax in the biennium that is upcoming here, the 21-23 biennium. And then just with the personal healthcare spending, that in Oregon, it's up about 44% over 10 years, and that our spending is accelerating faster relative to other states. So those were just some of the takeaways that we pulled out of the data. And I guess before we move on to this, are there any questions or comments about any of the slides that we just presented that folks haven't had an opportunity to share yet?
Nipper, this was an important and far-ranging discussion, which was very helpful. Thank you to the three of you for pulling this together. You started and nearly ended on the "it's complicated" slide, which showed these arrows going from payers to providers. It would be that's it. That's the man officer. It would be very valuable to us because this is about Oregon and shows pretty much a flow of every dollar in Oregon. You got to put it somewhere. If you could put a number on each one of those arrows, because some of those arrows are billions of dollars and some of them are millions of dollars. So I think you had mentioned earlier that the arrows size is not proportional to the amount of money.
Correct.
But it would be very helpful for us to have some idea of which are the biggest arrows here and how much money are we talking about. And we certainly understand that your hardship is you're trying to get numbers with from different sources, different definitions, different years, different completion. And we will not hold you responsible for being accurate to even 4 significant digits. Just something to an order of magnitude will really help us understand how much money we're talking about. Also, I think Dwight asked about the value judgment, is more spending good or bad? We should all keep in mind that spending on healthcare bears little relationship to need for healthcare, and that a state that spends more on healthcare might be providing more healthcare, or they might not.
Mhm.
And this is something Glenn would point out to us. And something else that we talked about, administrative costs. In one of the pie graphs, we should keep in mind that the administrative costs only are payer costs, that little slice of the pie for administrative costs doesn't reflect the fact that 25% of hospital spending is for administrative costs, and the 12% of office-based physician costs are administrative costs. So we should not underestimate the potential value of single payer at reducing administrative costs. I'll now ask for other people who specifically have questions about these slides. Chuck,
Sam,
you're up.
before you, can I just respond to your ask on the dollar and putting dollar amounts to this diagram here?
Yes.
So I think that's something we can take back and talk about. I completely hear, I think it would be great to have certainly a sense of proportional magnitude. I think some of these are going to be easier to put numbers to than others.
Understood.
So we will do our best. I think we're going to need to figure out like what's available and when and all of that, but we will certainly do our best.
And
Yes,
can I clarify, Sam, I'm hearing that you would be okay with some back of the napkin math to help flesh this out.
Absolutely. If one of these is don't know, that's okay. As we're just, where should we devote our attention first? So,
Okay.
understood. Thank you.
So the back of the napkin made me think earlier when we were talking about how difficult the numbers are. I started the image of Don Rumsfeld saying there are known unknowns, there are unknown unknowns, there are unknown knowns, and I think that's really true of this. So to Cheryl's comment earlier, I think the graphic, that middle box with Oregon state government should say state and local government in that chart. So back on that chart we were just on, the map, I'll call it. It's complicated. And then, and I do like Sam's idea, but I also I guess it should be, we're going to need context. We can put in how much of the state general fund, like the state and other taxes. It's the general fund that's going to Medicaid, but there's all, Oregon residents, it's not going to be the total state income tax and whatnot that's going to state government, and then showing what little portion's going out to Medicaid. It should just be that amount that's getting from general fund from its source, is I guess how I would do it.
One thing I just want to, and I can share this with you, like Laurel mentioned, this diagram came out of the Rand Corporation New York document, and they also provided a diagram of what they proposed this would look like under their new system, which might be helpful. It doesn't get to any of the dollars, but it is sort of helpful to kind of look at, here's one vision for how the financing of this might look. And so we can send that out too.
That'd be good.
John.
Yeah, two things. I was fortunate to tune in to the reimbursement committee when Chad was making his presentation about capital budgets. That is a variable in our work. And I think it would be good to understand, how does that work within this? What percent of a hospital budget is a capital budget? And how does that show up in these numbers? That's number one. The other thing would be, Medicaid, Medicare, and commercial have, let's just say, 3 benefit designs. And they have 3 different payment rates. It would be interesting, to start to figure out how would it work if the benefit design was the same for all. And let's assume it's whatever is the richest. I sense the Medicaid benefit is the richest, but I don't know that. And multiply that times the payment rate for Medicare. I mean, I know that that's been figured out or estimated in the Medicare for All stuff, and frankly, my sense from talking to hospital people is they've looked at those numbers. I think it'd be interesting to try and do that. Does that make sense?
John, I'm going to break this up into 2 stages. The first ask for the OHA is, what do these numbers look like now to the best of whatever you can dig up? And the second stage will be, how does our manipulation change these numbers? Which of these arrows get larger, which of them get smaller? And yes, it will be very interesting to find out, once we have the numbers now, how our tampering with it will make things better or worse for whom. Dwight, you have the question.
Les has his hand raised. I just want to make sure.
Oh, didn't see it. You're next after, okay, Dwight, Les, and then Chad.
Thanks. On this,
Cheryl.
This complicated chart, when we talk about provider taxes, and you broke that down well, I appreciate that. Where, if it's in here, or is it small enough that it's not going to be a big impact? But I'm thinking about local Medicaid match programs run through Oregon through public health, local public health, through education, through school districts and so forth. They have Medicaid match programs that they draw down, but they have to match with local dollars. Is that anywhere in here?
Yeah, that's a good question. I don't think that it is.
I think it is in the other public claims. No?
Well, I suppose
there's a difference between some of those services that are delivered by public health or by schools or other partners that are essentially delivering those services as a Medicaid provider. And in that case, the existing state and federal match all sort of flows through. And then there's what I think you're asking about, which is a totally separate program that's sort of a distinct benefit or service outside of Medicaid that may also be eligible for some federal match, yes. And that is not currently part of this chart.
Thank you, Bartleman. Boy, we thought it was complicated just looking at the slide.
It might be interesting to know how much of that there is, just to see how much is at play there.
Yes. Les, Chad, then Cheryl.
Hi, thank you everyone for your presentation. My question, I'm going back to the slide on the 2019-21 biennium for the Oregon Medicaid dollars. I think it's, yeah. And I was just going through and wondering the breakdown of where those general fund dollars, what programs are those going out to on the other end. I'm just trying to, I know like the IDD side and the disability side, and I know it's probably a big chunk of those funds if they're being included in that 1.6 billion there. So I'm just trying to figure out what, we have these federal matches, we have these other funds, and then we have the general fund, and where those funds are going inside of that dark blue.
I can take a first stab at that, but I want to be careful in answering this because there are some ways in which this is just one way to break it down, and this is not necessarily the way we pay out with all of these same distinctions. So one way to think about it is all of this money gets pooled, and then we can say, here's how it's paid. But that's not entirely true because there are certain services that the federal government doesn't pay for, or certain populations that the federal government doesn't pay for that we pay for as a state. And so that's where some of the nuance is, but there's not sort of a clean line where we say, these are the general fund supported programs. These are the other funded supported programs. It's here are all of the Medicaid programs that are paid for out of this pooled budget, although there is some variation in service and population.
Thank you, Bartleman. Chad, Cheryl, and then we're going to, as quickly as we can, then move to discussion of other issues and leave time for the public testimony. So Chad, you're up.
Thank you. I first congratulate staff on this work. I think it's admittedly very complicated, but certainly very helpful, and thank you for that. My comment is I'm curious about our ability to make moves. So I'd like to see, and it's probably not possible, but see an overlay on which of these dollars that are moving back and forth from which sources require waivers, and which are already subject to waivers, because you know, I know that all of the Medicaid activities going on in the state right now is subject to a waiver. But in addition to that, there may be other things that impair our discretion or our ability to move and create something. In particular, I'm interested in the Medicare element of it and the necessity for a Medicare waiver.
Chad, you'll be reassured to know that thank you, Oliver. We do have a scheduled presentation on ERISA and all other federal laws that will impact our ability to pool state spending that will address at least a few of your questions. This is from Dr. Liz McCuskey of UMass, who has written extensively on this. It's an important question. We will get to it, and I wouldn't expect the OHA staff to spend the rest of their lives trying to sort this out, because there are people who are spending the rest of their lives sorting this out. Cheryl.
I have a question, and then I have what I guess amounts to a value statement. So my question is, are we assuming, or have we made the determination that we have enough money in our healthcare system, it just needs to be redirected to different places? Or are we not ruling out that we may need more money in our healthcare system? And I'll just use the example of behavioral health. Behavioral health probably is about, I don't know, it's in the single digits percentage of the whole healthcare system. So I want to say maybe between 6 and 8%, at least in the Medicaid system. And prevention, all types of prevention, including suicide prevention, and mental illness prevention, but also, you know, tobacco cessation, all of those things might be 1% of the total healthcare spend. So I want to just first find out if we've made that decision as a task force, or we're still kind of figuring that out. So that's my first question. And then second, I totally understand that we're limited by the data that we can, that we have access to. But I do think if we're going to get to some sort of equity among health system components, I just feel, I feel strongly that we need to include behavioral health as one breakout group of healthcare. And I noticed in one slide it had dental broken out, it didn't have behavioral health, and prevention for that matter. Because I think if we're ever going to invest in these parts of the system that are so inadequately resourced, we can't see where we might need to move some funds from one part of the system to another part. I think we've got to break that out just to see the disparity among health system components.
Cheryl, thank you. Chuck, you had a comment in response to Cheryl, and then I'll follow you.
I don't think we have decided, and I hope we haven't, that what we're currently putting in is the correct amount in any area. So it does seem like we do have to come up with better numbers for that. And then I also just had a question on it's a complicated one, whether is that other public claims, that must include VA and tribal monies and stuff like that?
Yes.
In the federal box?
Yes.
Thank you, Chuck. Cheryl, a brief response. There's the gestalt of single-payer universal health care. Do we have enough money to fund it? We, of course, don't know because we don't have that in the United States, but any universal health care plan that we look at either privately or publicly in the US or in other industrialized nations shows that they all provide, they spend less than we do per person. You also bring up the point that sometimes healthcare costs go up and down because we redefine it. So healthcare spending in Oregon, if we define that as all the healthcare spending, even outside of healthcare, that goes into behavioral health, that spending goes up because not everything gets funneled through medical institutions for behavioral health. Likewise, long-term care. If we redefine healthcare spending in Oregon as everything we spend in long-term care, such as unpaid volunteer help and funding from other sources, it goes up. I'd like to say that the more services we include in our universal care plan, the more efficient the plan is. And the spending on everything, whether it's classified now as healthcare or not, will be more efficient. That's my soapbox. Do we have any more questions for our OHA staffers on this slide presentation? Nipper, you were going to move on to the next slide about topics we should be talking about now in our tag. And in fact, the faces keep switching. I think it was Chad who was talking about how do we preserve and maximize federal funding. That will be one of the biggest challenges our tag will face. And we're probably going to need to discuss this in the context of what would a super waiver bill in Congress look like that would enable us to recruit all of the federal funding now, even if we go to a universal care plan. I'd like to hear other comments on preserving and maximizing federal funds from committee members.
Les is raising his hand.
Okay.
It was me.
Thank you, Les. Please.
Yeah.
Didn't see you.
You know, so I brought this up before, and, you know, I'm just trying to kind of take my idea and help everybody kind of through what I've been thinking about a lot, which is, you know, if we're going to go the income tax route, which I think is a good mechanism because of its progressive nature, although I don't think Oregon's income tax is as progressive as it could be, as we saw in our last presentation. But, you know, the thing I think about is that, you know, the premiums that are currently being paid to insurers on behalf of by employers, those funds need to be brought back to the workers so that whatever system we come up with, the worker can use those in employer portions of the premium to help pay. But the thing I also have thought about is, okay, now that becomes income, and that's, you know, susceptible to federal income tax and state income tax, and that we probably need to be thinking about, you know, how do we either ask the federal government, please don't tax this income because it was being paid as insurance premiums before, or how could we get around that issue? Because I feel like we talked a lot about how do we get people to buy into this. I really hope we have enough money to in the system as it currently exists to create our single payer plan. And I hope that we could utilize those premiums coming back to employees to, you know, basically increase their pay, even if we are taxing away a good chunk of that. So I don't know. That's sort of what I've been thinking about a lot, and maybe that was a little convoluted. I should probably write it down and explain it a little better, but that's
Les, you make an important point that when we start shifting this money around, we may or may not increase take-home income for the people who need it the most, and we may inadvertently create higher federal tax liabilities by improving that income. It's a good point. Chad, then I think, Dwight, did you have your hand up, and then John? Okay, Chad, then John.
Okay, just following up on Les's comment, one of the things that some people feel, and I tend to feel, is that employers who have a certain obligation for contribution to the healthcare premium today should not necessarily, at least immediately, be taken off the hook for that obligation. Certainly one way you could do that is get it to the employees, but that, of course, as he points out, is taxable. The other way you could do it is you could make a tax, and that becomes an employer tax, and it could be gradiated over a period of time and maybe go away over a period of time, and maybe it could be added in to some kind of provider tax such you could draw down more Medicaid. I'm not sure.
Thank you. John, you're next.
Yeah, I think a priority should be Medicare and learning more about Medicare and the flow of funds in Medicare. You know, I mean, I'm always impressed lately listening to TV, which is sometimes all I have to do, and hearing the commercials from United Healthcare, that it's the biggest Medicare insurance company in Oregon. And I'm sure it is because of its Medicare Advantage plan, but also because of those supplements. You know, while Medicare only has, what, 15% of the people, it has 30% of the money. You know, Oregon has been a fairly robust Medicare Advantage state. I don't know, for example, how much money is in the end-stage renal disease program. Most folks, I think, would want to stay away from that because that's very challenging. But, you know, sometimes I think, well, would it be an option for Oregon to have a single-payer Medicare Advantage plan? Within the Medicare Advantage rules, could Oregon basically say the single payer is going to do a Medicare Advantage plan? Away we go. So, you know, combining Medicare and Medicaid, which is I mean, Medicare, I think, has more federal funds probably in it than Medicaid, would be a huge accomplishment. So to me, I'd want to know more about that fairly soon. I suspect Medicare, you're going to have to provide at least the Medicare benefit. They're not going to let you do less than that. They might let you do more, and there might be opportunities to do more. On the other hand, you know, there's a substantial number of people on Medicare who aren't in Medicare Advantage because they can't afford it, and you know, would be greatly benefited by it, but it would mean we'd have to come up with a significant amount of money to do that. Anyway, so Medicare is a high priority for me.
John, that's again an important point. There have been some state-based single-payer proposals that have attempted, well, have thought about just what you said. That is, we can't get a federal waiver from Medicare for the state. If we can't do that, then we will create a state-based Medicare Advantage plan available to everybody currently on Medicare. That is an option that we should continue. Are there other comments on the federal funds are there additional comments on preserving, maximizing federal or state funds?
If I could just add one more thing on Medicare, I think, you know, certainly Laurel will know, I've been to her enough about it, that I do think it's important for the state to get their arms around Medicare. It's typically not paid a lot of attention to because the money flows straight from providers to the feds and back again, and so it doesn't really flow through the state coffers. But I think one of the things to remember is that Medicare is a federal program, and it offers a lot of latitudes to Medicare recipients to move around the country and seek care. And so any Medicare Advantage or any ACO, mandatory ACO or anything like that, that limits that ability of Medicare recipients to move around and select providers freely, I think is going to meet a cold stare on behalf of the federal government and is problematic.
Thank you, Chad.
Yeah, I like this. I'm in favor of the discussion up here. I also just want to say I've been trying to figure out, and we'll learn more from the ERISA discussion down the line, but sort of how do we get health insurance to be seen by the employers similar to unemployment insurance and by employees as well? You know, there's a tax. You don't hear employees complain about the unemployment insurance tax, that it's not a bargainable issue really. The way it works is it goes into a trust fund, and annually they estimate how much they think they might need in the trust fund for the 100-year storms other than COVID, and the fund and the tax table adjusts accordingly. So would love to have more discussion in the group about how do you sort of incentivize employers to drop providing coverage but not lose their investment, which is for them to do it. I mean, but there's some entities that self-insure for unemployment insurance too. They're still making the investment. So I want to figure out how to do that on the employer side, because there's such a big portion of the population.
Les, did you have a comment?
I was just saying I agree. Chuck, I think that'd be great if we could convince them to treat it like UI insurance. Yeah.
Other comments on the first 2 points? Now, Nipper, in the latest version of this slide or on the agenda, the third question included a discussion of target year. I would like to bring the next slide. In that case, before we go to the next slide, this is our chance to give you more specific questions that we need to direct outside our committee. Actually, we do have some, we have alluded to some questions. John asked about the benefit schedule. If we can expect federal pushback, not to mention pushback from every Medicare patient, if our benefits aren't at least as good as Medicare. And of course, that's something for the eligibility, benefits, and affordability. John.
Yeah, I was going to bring this up at governance, but I'll bring it up here. The bill describes the single payer at least twice as a public trust. What does that mean? The words public trust are actually in the Constitution. From what I can read, and not a lawyer, there's some interesting conversations about what does the term public trust mean, are there some advantages to doing this as a public trust that would be meaningful and helpful?
John, a snappy answer, not the definitive one, is we can determine what we need public trust to mean and then define it that way so we can get the work done that we need to. It also has relates to what Chuck has been talking about. Will people of Oregon feel more comfortable if what they're contributing to is a public trust as opposed to the dreaded tax? And a good part of this is the gestalt of how we present what we're doing to voters and legislators.
Exactly.
Other comments on that last point that Nipper has displayed? Okay, Nipper, shall we scroll to the next slide?
What?
So these were just, I mean, these were questions that we had heard from the co-leads, and then just things that we, you know, have been mentioned over email. We have the target year question here, and we wanted to make sure that these pieces were represented here somewhere, and also see if there were just other questions that have been floating around people's brains as they're looking at this. I know we've heard quite a few already, but we just wanted to make sure that we were giving space to that.
Nipper, I think that the additional figures that you come up with for the "it's complicated" slide may help us understand this top question of employee-sponsored plans versus individual plans. I'll go first on the second question. Administration is in the eye of the beholder, and a good part of what Oregon spends on administration doesn't get carved out in anybody's pie chart on administration for reasons that I mentioned previously. We can expect our single payer plan that has a uniform billing system, a uniform insurance forms, uniform benefits, uniform risk pool to reduce administration for everyone, including the unpaid costs for people to figure out what their insurance is going to cover and the time they spend on the phone to their insurer. What are other thoughts on how much attention we should pay to this second question of administration?
Well, I'll go. I'm unmuted, yes. So I think of it in terms of, I think we're going to have to get some estimates further down the line of, based on our design, whether there will be efficiencies, what that saves. And then the other thing that sort of popped in my mind that I still haven't gotten, I don't know how to ask the question other than to say we're sort of all avoiding the word profit. And, you know, I pay into money to an insurance company monthly, and if I don't get drastically sick and I have deductibles, right? And then they're making a profit off that. They make their profit off of me not getting sick or using the healthcare system, as well as investments of all of our. And so how much, where's the profit in this that if we switch to no insurance companies or just administrative ones, how much profit is in that it's complicated chart? Especially on the insurance, on the intermediaries that make it so complicated now. Separate from hospital profits, maybe, or doctor profits or whatever, certain specialty profits. But in the insurance area, it seems like that's a big chunk. As well as, and pharmaceuticals, I guess would be the other one too, because of the markup.
Laurel and Nipper, you now have to answer this socialist question of how much profit is being skimmed off of our insurance and pharmaceutical dollars. You should know that we'll accept near guesses because, as we know, all of the for-profit firms that deal in healthcare have proprietary information that is not accessible to us mortals. But some estimate informal estimate, non-binding estimate on what Chuck is asking would be helpful. We
Well,
do know,
insurance regulators have some sense of it. So
yes, we also know that we have one CCO in Oregon that is owned by a for-profit company, and those profits aren't returned to Oregon. But if we had a number and we could say it's small enough that we can let the bloodsuckers get away with it, or we can say this is significant and we need to put this into our calculations, that would help. Chad.
We will try. I think that area is going to be honestly really tricky for us to come up with some things, but we can also have a conversation with some folks at DCBS. So
thank you. Chad, and then John.
Well, there is some standard nomenclature. Paid claims ratio is a good comparable number, and that data is available. It does overlap with the notion of administration. So if you take the money that is not paid out in claims, well, a lot of it could be construed as being used for administration on the insurance side. So there are some comparable numbers that could be used a little bit. Certainly Medicare, for example, runs at around 3% or 3 or 4%, and private insurance organizations at around 20.
Thank you. John.
Yeah, this conversation just reminds me as an old guy of one of the more memorable days of my life in the late 90s was a huge contract negotiation between, let's just say, a very large medical group and a very large hospital plan. And the meeting began with the chief financial officer announcing that they had made the decision, their board had made the decision to move from a 2% profit margin to a 6% profit margin. That changed the world. That changed the world. I'm not sure where that number is these days, but I think for nonprofits, much of it is up to them. Yes, Chad probably knows more about maybe bondholders. They prefer 6% probably than 2%. But it's interesting. I mean, I hear people in the market talk about those numbers, and definitely when it comes to hospitals, that's a significant variable.
Thank you for that chilling statistic, John. Other comments on administration? I'd like to frame the next question as multiple choice. We eventually will need to have numbers, estimated costs of healthcare for a target year. And that, of course, means that we will need to have estimated tax revenue for that same target year. The question I'll propose to our committee members are, should we decide now that we should pick a target year that we should all work toward? Two, if we're going to do that, should our tag do that, or should the full committee do that? And three, if we should do it and our subcommittee should do it, what year should that be? So before I call for raised hands, comments on this issue? Chad.
Sorry.
I'm sorry. It seems to me it emanates from the benefit package, and that you have to start there. And that includes co-pays and cost sharing and everything associated with who and what is being covered here, and then sort of roll it up from there.
Chad, I'm not sure I made my statement clear enough. I'm not asking for any estimates now. I'm asking for what should be the target year, so that when we ask for when we ask for estimates, we make sure that everybody is giving us a projection for the same year. My fear is that we will have a projection for spending in the year 2023. We'll have a projection for revenue in another year, and we'll have another projection for another year. So I would like, when we make our requests for projections, that we ask everybody for the same projected year. Did I not quite make that clear?
I'm with you, Sam.
Okay.
I'm getting,
Chad, you still have a wrinkle on
Well,
your forehead.
I guess I feel like the bottom line here is the implementation year, and everything backs up from there.
Thank you. Yes, I think that's a much better term. Are we looking at an implementation year of 2022 or 2026? And do we want to be thinking about what that year should be? John, you had a comment, then Chuck, then Les.
Yeah, again, an issue I thought would come at the start of the governance discussion, and that's, should this be an incremental implementation or all at once? You know, I think I could make a case for bring Medicare and Medicaid together and show you can do it and show you can be successful at it, and manage that amount of money. And then take on commercial. So there may be increments you want to consider. I mean, I hope that what we do, something very significant would happen by 2025, in 5 years.
Thank you, John. It is my hope that our committee, our full task force, comes up with a single payer plan and then has additional alternative plans if we think that we can't do that. And if we have a single payer plan, I think there's no incremental way to get to a single payer. You leap across the chasm. You don't do it in small steps. Eventually, if the ETA, I'm going on here, if the EBA committee says, we're giving you 2 or 3 different plans, some of which implement what you just described. We're going to start with combining the federal programs. Then, of course, that will influence the implementation year. There may be multiple implementation years. Chuck, then Les.
Yeah, I don't think we need to worry about that, because I think we get numbers for sort of the most current numbers for, someone can say, if it got implemented today or in the upcoming biennium over the next 2-year period, but it's all going to depend on what we design. You know, the Oregon Health Plan was enacted in the 80s. They didn't know it would take until the middle of the 1993 legislative session to get federal Medicaid waiver approved, right? I mean, that didn't stop them. They may have guessed that, but they also, it wasn't contingent on that. The planning wasn't based on that particular year or anything. And so I just don't think we need, I think it's way too premature for that, you know, and I understand you're wanting to jump across the chasm. If you heard, Sam, that we can do everything except this one little thing we need Congress to tweak, you would probably say, okay, let's go forward and have that part later. It wouldn't surprise me. And so I just think it's way too early to worry about what year. I should say sort of the soonest, the most current numbers you have for the current year, or if we did it in the, you know, if we did this in the next biennium, and then we'll get down the line, we'll learn how long it'll take to get waivers or guesstimate on congressional action and other implementations barriers to doing it tomorrow. And then on the revenue side, there's barriers. Certain taxes can get up and running right away and certain have delays. And so I'm not hung up on the year issue. I think things can be put into next year's bundle, and then down the line, you tweak the details on the revenue side for when it's getting implemented.
I have a comment, but Les is up next.
You know, since we budget on the biennium and we won't be ready with our plan at the start of this session, you know, I think aiming for the next biennium is probably a good place to start. Just logistically with how Oregon operates. You know, and I wish that you know, maybe at the next meeting, you know, the senators and the other legislators that are part of our group can tell us what they're thinking in terms of timeline. But you know, that's what I would say is, you know, looking at the next biennium and saying, okay, what could we have in place for the next biennium for decisions to be made during those legislative sessions.
Thank you, Les. I can tell that I have misled everyone about what I'm hoping to do. I do not want our tag to pick the year of implementation. I agree with the comments that there's just too much squirreliness here. We cannot pick a year of implementation. What I fear is that we are going to ask the OHA to project healthcare spending to a date in the future. We're going to ask the LRO to project tax revenues for a date in the future so that we can come up with enough taxes to pay for the projected costs. What I fear is that we will have 2 different years that we ask for projections so that we come up with enough tax revenue to fund in 2025, but it's inadequate to fund and implement the estimate from the OHA for 2023, to use these just for examples. What I'd like to do is we have 6 members of the committee. I'll ask if there are any more comments, and I'm just going to ask the question, is this an issue we should determine now? Any other comments before I call for a vote? All right, Glenn, you're up. Unmute yourself.
I got it. Thank you.
Good.
I just think that perhaps we should consult with the other tags because is this the only means that we can anticipate of financing and generating revenue to pay for this robust single-payer universal healthcare system? There may be more input to give us a wider a vision of how we can pay for this system. We want to be innovative and creative in our thoughts and ideas so that we can eliminate all of this other Medicare, Medicaid, private, commercial types of health plans that we all know does not work or, you know, benefit our society or our healthcare consumers. That's where I'm at on it, and I like going big and bold and thinking beyond the box. I do not want to get mired down in the current healthcare payment system that we have just to change a term or phrase or 2 around and apply it in our design, expecting a different outcome.
Thank you, Glenn. I'm going to call the question, and for the 6 committee members here, I'll ask you to raise your hand if you think this is an issue we should determine now. And Chad, your vision is off, so you can say aye or nay. All in favor, raise your hand. Boy, it's lonely at the top here. We will not discuss this any further, and we have time for public input. Charlie, I think you had wanted to say something, alerted us that you might want to say something. Why don't you unmute? You're unmuted. Why don't you take it from here?
Thanks, Sam, and thanks, members of this tag. So I have comments related to a couple points. One is the estimate of healthcare spending in Oregon in 2014 from CMS. We should note that that's personal healthcare expenditures. That was not total healthcare expenditures. So that means it doesn't include insurance costs, it doesn't include public health, it doesn't include investment. It's the CMS, definition of personal healthcare expenditures. So the other comment is also related to personal healthcare expenditures, and it's related to the slides that came later that showed personal healthcare expenditures and Oregon's, rank by state. Those personal healthcare expenditures are not out-of-pocket costs. I mean, they're nothing close to what out-of-pocket costs are, but they're also not personal healthcare expenditures as defined by Medicaid. So I'm not quite sure what they are. I will try to figure out what they are, but they're neither of those things. So they're not comparable to the other ones that we do know what the definition is. So it's confusing what that slide might mean. I don't have any idea what that definition is, but we do know that it's not out-of-pocket cost and it is not personal healthcare expenditures as defined by CMS. So I have a comment on several comments on the "it's complicated" slide. It's missing some very important large money flows that are over, they're in the billions of dollars. So, for example, and I can understand why it's missing some of these. From Oregon employers, there should be a line directly to healthcare providers because of self-insured plans. They might use insurers as administrative bodies, but they do not pay the insurer within which pays. So that money, they're self-insured. So they don't use insurers other than as administrators. So there really needs to be a line there. And that line is billions of dollars. Another line of importance, I think, is and it's not quite clear if it really fits on there or not, but it's the tax expenditure, both federal and state tax on employer paid premiums. So there should be a line going from the federal government to the employers, and probably from the Oregon state government to employers too, although that's going to be a smaller line. I don't know what the numbers are for that. There's certainly some other littler lines that people have mentioned. There's money that goes, for example, from that gets paid sort of just pass through at the state. So the state really doesn't do anything other than just pass the money through. There is Oregon Medicaid money that actually goes back to pay Medicare premiums. So it's money that comes into Oregon state government, and then the state Medicaid program, and then goes back to pay premiums. So that's a smaller amount, but it's still a couple $100 million. So there's some other lines missing, but those two that I mentioned first I think are important to have there because they are really big numbers, and they're really important because of one, it was related to ERISA, and the other is it's important for Oregon to do what it can to not have the money that stays in Oregon because of the federal tax expenditure on employer premiums to go away from Oregon. So that we want to try to keep that in. So there's important numbers to think about, important things to think about. I can say just a little bit about the public trust notion. One of the reasons, there's probably a lot of reasons why the language is in the bill, but one of the reasons the language is in the bill is because the notion is that if a community, and this relates to community planning, et cetera. So if a community saves money by doing something to promote health in its community, and so there's less money needed, that benefit needs to remain in the public in that community. That was kind of the notion, that's one of the notions of what public trust is about, is trying to keep that money in the public, in the community that is, so it can benefit from those kinds of things. There's other meanings to it too that are intended in the bill, but that's one of those. Another comment is that we're hoping, activists are hoping that by the time you guys come out with a plan, it looks like Congress is going to pass the super waiver that Sam talks about, and we're gonna try to make sure that super waiver answers some of the questions that some people would like to try to preserve the federal matching money. There's some language in there that sort of does it already in the proposed bills, but there's probably ways to improve it. So we'll be looking at that. And thanks for everybody for all your work.
Thank you, Charlie. Chuck, did you have a comment?
Yeah, Charlie. So on the tax expenditure, I think it is in the chart. It's the line going from right to left, from federal government and from state government back to residents, that state exclusion for employer-sponsored insurance premiums. That I think is that line.
Chuck, I'm not sure, because that line, it looks like it's to subsidize individuals and families.
Not employers, yes. I think it should go to employers as well.
And
right, it should go to employers as well. That's right. But
that's the line I'm saying is missing. Yeah, and that's a several $billion line from federal government.
The state line is 1.6 billion back to individuals.
But the federal government line back to employers is over 2 billion. If you look at the RAND report, I think they estimated it at 2.6 billion. And that was 20 years, and I think they underestimated, but it's the right ballpark. So,
Charlie, I think you're right, and I would like to ask if Nipper and Laurel could, on their chart, show a line between the federal government and Oregon employers. It's not there, that reflects the federal tax deferment that employers enjoy by deducting their insurance premiums. Just so we all know, that is the single largest tax deferment. What is the term, Charlie?
Tax expenditure.
Thank you. Tax expenditure in the United States. We're talking several $100 billion in unpaid taxes. And this will play into something that Les was concerned about, which is how much will employers return to their employees if they're not paying for employer health care. And the second line you asked for, Charlie, I think is also important. When we see that line between Oregon employers and insurers, it says premiums. There is a line that bypasses insurers, as you state all of the self-funded plans. And that is relevant because that will likely be the last bastion of ERISA protected spending that we will see. And we should have some concept of what that number is. So Charlie, you've been heard, and I second your request. Chad, you had a comment.
Yeah, just a quick question from Charlie. I'm really unfamiliar with the work that's being done on this notion of super waiver, and I think that it would be good for this group to be aware of how that's evolving and what's really doable in the context of the super waiver. For example, the kind of things I spoke about earlier regarding Medicare recipients' ability to move around and pick their providers. Do you have any summary of what's going on that super waiver? Because I would certainly be interested in it.
Yeah, so the bill is, in the last Congress, it was HR 5010, and it was co-sponsored by 3 of Oregon's representatives. So DeFazio, Blumenauer, and Bonamici all were co-sponsors on the bill. There weren't anywhere near enough other states that were, to make it, very excitable, but it may get a better hearing in this next Congress. So pretty much everything, the state can ask for a waiver of pretty much every federal program other than the Veterans Health Administration and Indian Health Services. But other programs, they can ask for a waiver. And among the sorts of things they could ask to be waived would be to say, we want to include Medicare in our state program, and we want you to waive the penalty for people not being able to choose whatever Medicare they want if they go out of the state. So if you know they join the Oregon plan and therefore have not chosen a Medicare Advantage or a Medicare supplement plan, that when they leave the state, or if they leave the state, they could go to another state and say, well, it's as if you're a new Medicare recipient. The state could ask that to be waived. Another example of what the state could ask to be waived would be for federal employees. Right now, if you haven't had, I think it's 5 years of continuous, or if you haven't gotten insurance through the TRICARE within the, or no, this is federal employees. Through federal employees in the last 5 years, then you can't get that plan again. And the state could say, well, we want a waiver of that requirement. So pretty much everything, the state could ask for a waiver, but I think the state would have to specifically ask for all those particular things. Now, whether or not this is going to pass, who knows? But it's possible, in part because Becerra, the CMS newly appointed, well, will become the CMS or not CMS, HHS director, is strongly in favor of these sorts of things. So I think there's hope for this.
It just feels like, you know, it's a bit of a third rail, and you know, would lend itself to oversimplification, and I don't know. I can just hear AARP on this.
Yes, you can, and they have spoken specifically about this. Thank you, Charlie. We will be revisiting this whole concept as in the task force as a whole and in our subcommittee. So we will stay tuned, and we'll ask you to summarize this again. Are there any other public comments?
Sam, can you hear me?
Yes, Alex, you're on.
Is it okay to make a quick comment?
This is the time and place. Thank you.
Seem to always be at the end, and so I hope people don't mind. Hope I'm not extending the meeting more than a couple minutes here. But I noticed on your slide here you're showing revenue as the next meeting. I just wanted to comment, since this how the employer-sponsored part of it is going to feed into it. I know this is going to be addressed down the road, but since the tag has been discussing it now, I just wanted to put in a brief comment, and that is when Mid-Valley Healthcare, our legislative committee, put together a report on how this would all be financed. One of the options we looked at and we included was a tax on employers along with a general tax, and in that way. And we look at how that would dovetail in, and it turned out that with a tax on employers, most employers who are currently providing employer-sponsored insurance would actually wind up paying less if you taxed employers kind of concomitant with a general income tax. So now, employers who are not currently doing anything for their employees as far as employer-sponsored insurance, they would be complaining because they would have to kick in more. But you could always argue that if they're not, the employers that aren't contributing now are putting that onus and that burden, in the social sphere, and their employees are the state's having to pay for that through Medicaid and so on. So it's a matter of fairness. But I just wanted to point out that since it's been brought up as a topic, how are the employers going to do? What are they going to do with this money that they were currently paying to employees? If that was part of the revenue that you tax the employers, then like I say, most of the ones that are currently providing insurance would wind up better. They would be paying less, and then you would just hear from employers that aren't currently providing that. So I'm sure that'll be addressed later on. I just wanted to put forward that point. And thank you so much for the tag for all your work.
Thank you, Alex. Do we have any other public testimony? Nipper or Laurel, did anyone else say that they wanted to speak today?
I don't believe so. I did, we had that last slide up because we had set aside 15 minutes to try to talk through what our next meetings would be. It would be great if we could return to this perhaps next time around so that we do have some semblance of an outline of where we're going here. It would really help staff as we're trying to pull various pieces together. So I'll flag that that perhaps we could discuss this next time around.
I had skipped to public testimony, Laurel, and I deprived you of your awarded time, and I apologize for that. Can the members stay for another 15 minutes so that we can get the OHA staffers set so they can prepare for following meetings?
You know,
I've got to leave. I'm sorry. I'm already 10 minutes late for another meeting. I'm just packed. So,
understood, Cheryl. Thank you very much.
All right. Bye, everybody.
And I believe we have a hard cutoff, the staff at 3:15. So unfortunately, I don't think we can have this conversation now. But I just wanted to flag that it would be great moving forward if we could have all the other tags have had this and it's been really helpful. So I just wanted to offer this that we can check in on this next time around.
Thank you for the gentle reminder. We will make this item number 1 for our next committee meeting. Thank you for tolerating this. Any other final comments before we officially close? Dwight.
Yeah, I was trying to find a schedule of upcoming meetings. Somehow I've lost that, or it doesn't exist. Do we have another next?
We don't. We were waiting on this was part of that, was trying to get a sense of when we were going to be meeting next, what our next items are, because the other tags, you know, were on that initial starting point. This tag started a little bit early and we're trying to spread it out a little bit more. So we were hoping that we could have a semblance of an outline so we could try to get some of these tag meetings scheduled.
I got disconnected for a little bit, so you may have already mentioned that, so I apologize.
No, we didn't.
Laurel, to help make up for this, I'll work with Chuck to see if the two of us can come up with some working outline that works with your schedule, and then it'll be our responsibility to circulate that to the group to make sure that it's consistent with other expectations.
That sounds great.
Okay.
That sounds great.
Thank you all very much. It's been an intriguing meeting, and we'll be back. Bye now.
Thanks
everybody.